Okay. And if I cough, please forgive me as I'm getting over a cold. So, my purpose today is to give you just a little bit of an introduction of how IRBMED reviews applications that may utilize mobile medical applications. And then I'll touch a little bit also about devices, although the focus isn't necessarily about devices, because there's a whole lot that can go into devices. And that's a whole other basket. So again, my name is Monica Stiddom. I am a senior regulatory analyst at IRBMED. I am also the B2 board's full lead, which means I am the only person on that board. So we're going to talk about the consents, we're going to talk about the applications, and then I'm going to delve just a little bit into the FDA aspects. So the main thing I want to talk about is everything that you want to do in your research needs to be in the consent. So this is how you are going to tell your subjects what you want to do. It's also where the IRB is going to go in addition to your protocol to find out what your research entails. Because the mobile medical application and device part of it is just one small part of your research. So it'll be really hard for us to find in your protocol that information. So we will rely a lot on the consent to just get real into that. Describe in great detail what you want to do. If you're going to track locations, get in there. Tell them what you're going to do, and I'll get into a scenario about this in a little bit. Um, you know, inclusion, exclusion. Um, if if your application or I'm sorry, if your research involves a mobile medical application, obviously, do they have a smartphone? There are still a few people who currently don't have smartphones. So you need to ask them, do you have a smartphone? Are you willing to download an application? Um, do you have Wi-Fi at home? Do you have enough minutes? Do you, these are the things that you need to put in your application, or I'm sorry, into your consent. Um, if smartwatches are part of the project, are you providing them or are they using their own personal devices? Um, if you are, this is one part where I'm going to talk about the devices. If you are providing them, don't name the device. Keep it generic because throughout the life of the study, it is unlikely that you will be able to keep the same device. And my friends from the Apple study will know this because it's a long study. You may go through 3 or 4 generations of Apple Watches before you reach the end of the study. And then you have to continually submit amendments as you go from version 1 and 2 and 3 and 4. And I don't even know what versions of Apple Watches they're in now. So just say we will be utilizing one or more smartwatch, etc. And then in the risks, there are some, believe it or not, there are risks associated with using smartwatches. You may experience an allergic reaction to the type of band. If that is the case, we will work with you to find a type of band that you may not have a reaction to. So there are some sort of off the wall. From my understanding, the skin tone plays uh, an, an effect on the readability of smartwatches. Persons with darker skin tones may not have as good readings as people with lighter skin tones, again, from my understanding. So these are the types of things that you may have to think about when you're putting them into your consent. Um, the other things that you need to do is in your consent, any applications that they download and that they have to create an account for, you need to put the complete URL, not just a hot link, because they're going to have a paper copy ultimately. You need to put that whole link in the consent. So you want them, or we want them, sorry, the IRB wants them to be able to go to that link and be able to read the end user agreements or the privacy agreements related to that. Related to that application. So for example, if part of the study is you're going to give them a free blood pressure monitoring cuff, we want them to be able to read the privacy agreements related to whatever company blood pressure machine that is. Okay, and any other related. So for example, if you are giving them an Apple Watch and they have to sign in to the Apple Watch, we want them to be able to read Apple's privacy agreements. I think that was pretty much it. But anything. So anyway, so the moral of the story is there is a lot that you can do in relation to the consent related to procedures as long as it's in the consent. And we get a lot of questions to the IRB. Oh, is this possible or is that possible? Well, is it in the consent? Well, no, it's not in the consent. Well, then you can't do it. So one of the studies that we did have come in. What I'm going to kind of cobble a couple of studies together to give you an example. There was one study that they wanted to track locations of subjects, and they put a tracking application on the phones with the subject's full knowledge. The study had a certificate of confidentiality because these subjects had previous run-ins with the law, and what the study team wanted to know is if they were avoiding specific locations. Okay. And so what they did is every month these subjects reported to the study team. The study team downloaded the location data from their phones, and they were able to tell from that data how close to specific locations that they were getting. And the reason they got the COC, the Certificate of Confidentiality, is because their history was with drug offenses. And what the study team wanted to know is how close that they were getting to known marijuana dispensaries. And so with this information, they were able to see, oh, on such and such a day, they came within 15 feet of a drug dispensary, but they couldn't tell any farther than that if they had gone inside, but they could tell they were within, say, 15 feet of this known dispensary. Now, that was as much detail as the study would go into. And so all of that was explained very clearly in the consent. The subject understood by providing this data, they had a COC. So all of that, so there was no deception. There was no anything. They were very upfront with what they were tracking, and the IRB approved it because straight to the point, we told the subjects exactly what the study team wanted to do. So we had no trouble approving it because The study team held nothing back. This is what we wanted to do, point blank, end of story. So, actually, you know, we didn't ask if there was going to be any questions. Anybody have any questions so far on the consent related to this?
Are you planning to have some examples like from actual studies?
Right. So we are going to, or they are creating a sample library with consent language that will be available to you guys. So you guys can like literally just copy and or see what's already been created. And there will be a link later on in my slides that you guys can just click on. I have a resource page.
Please.
And over time it'll get better. So it's starting small, but we will have it available for uploads. So as people create more and we find more, we will upload more.
And if any of you have example consents that you've used in studies, feel free to submit them. We are going to be sharing them on the knowledge base, but the only they're not going to be public. They'll be under a level 1 login. So if the faculty you work with are concerned about who's going to see it, only individuals from the University of Michigan will be able to access it, and those individuals with a level 1 login.
So, yeah, so it'll be a closed group. Okay, all right. So now the application. So the current e-research application, you are looking at what we ask about mobile medical applications / devices. This is it. It's basically one question with one follow-up question. That's it. Otherwise, we rely on the protocol and the consent. We kind of really in the application, we're really just looking for a yes and no question and a little bit of information here, which really we're going to look here and say, okay, that's nice. And then we're going to refer to the protocol and the consent. So what you put here, it's going to be really brief and really not a lot of helpful information. So I kind of just gave you a real general idea of what we're looking for, but it's mainly we're mainly going to look at the protocol and the consent. We were hoping next gen e-research was going to be better. But now that it's been tabled permanently, we don't know what's going to happen. So there's not a lot of time to spend on this. There's not a lot of anything here. So again, now we're with the protocol. So this is my own little plea for those that have control over protocol development. When you're working on your protocol, it's your protocol working with the mobile medical applications and or devices. It's going to be spread out throughout your protocol. Totally understandable. But if you could maybe just do a header that says mobile medical applications and give us like 1 or 2 paragraphs of just real point blank, this is the usage, that would be incredible. Because when we are looking specifically for that information, because we do have to make a determination at our meetings regarding that. And when we have to go back to look for that information, it's easier not to have to look through the entire protocol again just for that information. So that's my own little plea. Again, and sometimes we can get it from the consent, but oftentimes we have to go back to the protocol. Okay, now the FDA. If, as I have talked about in the past, my own preference for handling reviews is anytime I get a mobile medical application and or a mobile medical device, I treat it as if it were an FDA regulated study. And the reason for that is even though the current project may not necessarily meet the criteria for an enforcement discretion, chances are the next study or even the study after that, which is going to use this data to build on, may fall under that criteria. And it's easier to then use that data, or this data, if we have treated all of the projects as if they were FDA regulated. Now, what that means is it goes to full board once, and every year it has a continuing review that has to be filled out. That's pretty much it. Other than that, it's handled the exact same way as if it were not FDA regulated. That being said, depending on the type of project, if there are potential mobile medical devices, such as you're developing a new device that's going to monitor something, we may send you to MyOp to see if it needs FDA clearance, or if it is not quite to the point where it needs FDA clearance, but maybe we're going to have you fill out the IDE checklist for non-significant risk, and then the IRB is going to grant the non-significant risk for the device right now, which is sort of a intermediate first step for a new device. I know that's kind of confusing, but like I said, I wasn't going to get
Yeah,
too
I
deeply
don't
into
think that
devices.
I don't think that would apply to most of these, Monica.
Right. That's what I'm saying is
Yeah.
I just wanted to kind of give a hint that devices are handled differently. But there's also a chance that there could be an application that falls into this. So say we were developing an application that is going to run algorithms to do X. Excuse me. And it is possible that that algorithm could be, I was hoping my voice would hold out. It is possible that that algorithm might be determined to need to be evaluated. So we may just say, hey, call MyOp, just run it by them, and they'll know. It doesn't hurt. It takes a few minutes, and they may say, nope, you're good, and all is well.
What's
So.
more common is that there's an app related to manage the study management. So like a My Data Helps or a LumaView or Ripple or some other platform that enables remote studies. And those often have an app related to them.
Right.
So how is, because they don't I mean, those are,
It's not going to happen often. It's
yeah,
just
so it's
since
only,
it
so
is
it's only,
possible, I just wanted to put it out into the wind.
you know, I'm just trying to kind of tease out that in order for an application to be fall under the FDA approval, it needs to actually do something, like it has to have some kind of, like you mentioned, an algorithm.
Like I said, it may be 1 in 1,000.
Okay.
I mean, so I'm not even sure. Like I said, it may be.
But in general,
In
most, like
general,
if
it's
we're
not going to
using
happen.
if we're using a
Yeah.
product like My Data Helps, the
No.
application is not likely
Yeah,
to be.
it's not likely.
Okay.
And especially My Data Helps. My Data Helps is not ever. That's not what My Data Helps is. But it is possible that at some point somebody is going to come across one. So that's why I just wanted to throw this in there, that at some point, if somebody sends something to us and we say, you know what, you may have to talk to my app, you're not surprised.
So,
So,
Monica, so it's using, mobile data to develop an algorithm. Let's say they're using HRB to detect infections or to predict depression. The algorithm that they develop, if they want to put it into an app in the future, so I think you're saying that they wouldn't be able to do that unless they follow this process now, correct? Because that would
I'm not saying that 100%. What I'm saying is it is possible that if it gets to that point in the future, the FDA may look back and say, at what point did you start using data in studies that were considered FDA approved? So I'm not, so the FDA has this really weird things when it comes to mobile medical apps. They're behind. So they are just now catching up with devices, and they created the device regulations 20 years ago. So mobile medical apps have been around now, what, 15 years? So they're real behind. So they are still, sorry, my voice isn't going to last much longer. Oh, okay. Thought I have one more. What we're saying is we don't know at what point the FDA for mobile for mobile medical apps, they're going to let the flag fly. For drugs and devices, everything has to follow the FDA. For mobile medical apps, they're not there yet. So we don't know when they're going to do that. So we are being precautious by saying, let's just treat it like we do with drugs and devices. And just treat it all. Because we don't want to miss the opportunity of using all of this good data and just have it go to waste.
that makes sense.
When it really, like I said, the only difference is it goes to full board and we maintain an annual review. That literally at this point is the only difference. So
That seems reasonable.
yeah. So here's the link to the sample consents that are currently, I don't even know if there's anything currently uploaded yet. And then my information. I've included my mobile. I've disconnected my work number because it goes through whatever the university's link at home, and it doesn't like me. So just call me on my cell phone.
Monica, can you put the link in the chat so that I can add it to the agenda?
Oh, it's the one. It's the yeah.
Is it the article?
Yes, it's the that one.
Okay.
So, okay. Anybody else have any questions I can try and answer with before my voice takes a leap? Or have a general IRB question?
I think we're all just processing all this